So I'll be talking about the study Avoidance of Radiotherapy for Low Risk Early Breast Cancer using LUMINA Trial criteria and accounting for endocrine therapy adherence. So adjuvant radiotherapy is a standard component for breast conservative therapy for early stage breast cancer. EP-CTCG meta-analysis has shown that radiation therapy halves the 10-year rate of any breast cancer recurrence with an absolute reduction of 15.7% and reduces the 15 years breast cancer mortality rate by about 1/6 with an absolute reduction of 3.8%. After radiation therapy, the 10-year gain in radiation recurrence is more in node positive as compared to node negative breast cancer patients. However, radiotherapy is not without risk, and some patients at very low risk of relapse, the risk of radiotherapy may outweigh the benefit, leading to potential overtreatment. Randomized controlled trial have shown that omission of radiotherapy in low risk breast cancer does not reduce overall survival or increase breast cancer mortality, and the breast cancer recurrences are salvageable. As you can see, there are multiple studies in which, although the local recurrence rate are higher, but those are salvageable and there is no difference in overall survival. However, it did not change the practice due to concerns, mainly that the lesser duration of follow-up was there in this trial to identify the late recurrences. Lack of information regarding histology, grade, margin status, or presence of lymphovascular invasion was taken into consideration while design of the trial. And clinicians feared that endocrine therapy compliance could be less rigorous outside the setting of a clinical trial. In modern era, there are tumor subtypings assessed through immunohistochemistry, genomic expression, or signature assays is a promising strategy to identify a subgroup of low-risk women whom we can whom adjuvant RT can be spared after breast conservative surgery. There are different clinical studies presently going on, which are using biomarker-based trial, like LUMINA Trial, IDEA, Precision, Prime Trial, Expert, which are using various selection tests, and they are omitting radiation in these trials. This study is a retrospective study in which they have identified women with pathological T1, T2, and breast cancer treated with conservative surgery between 2000. The inclusion criteria from the LUMINA trial were used to select very low risk population, and subgroup analysis was performed to investigate the influence of endocrine therapy adherence to an outcome. They reported a treatment outcome with low risk ER positive early stage breast cancer treated with adjuvant RT or RT omission. Data collected include demographic features, tumor characteristic, treatment type, endocrine therapy adherence, and loco-regional recurrence events. To identify the trial were applied, such as age more than or equal to 55, unifocal unilateral tumor with ductal, tubular, or mucinous histology, T1, N0, grade 1, grade 2 tumors, ER, PR positive and HER2 negative, LVI absent, cut margin more than 2 mm, KI 67 less than or equal to 13.25, and patients agreeing to start endocrine therapy. 5-year local regional control rates were compared across group using the Kaplan-Meier method. 110 patients met LUMINA inclusion criteria, of which 82 were treated with EP-RT and RT was omitted in 28 patients. Endocrine therapy adherence information was available for 96 patients. In this study, patients who completed 5 years of endocrine therapy or discontinued owing to disease recurrence or death were categorized as endocrine therapy adherent, and those who discontinued before 5 years due to other reasons were categorized as endocrine therapy non-adherent. This table shows patient tumor and treatment characteristic. The median age in the RT group was 63 and in the RT omission group was 73 years. Majority were ductal histology. Endocrine therapy median duration in RT group was 60 months and in non-RT omission group it was 55 months. Results showed that the median endocrine therapy duration in endocrine therapy adherent group was 60 months as compared to non-adherent group it was 19 months. 5-year local control rate for RT was 100% as compared to 94% in the RT omission group, which was significant. On subset analysis, 5-year local regional rates for RT and RT omission were both 100%. And in patients who were not adherent to the endocrine therapy, the local control rate was 100% in the RT group and 83% in the non-RT group. So they concluded that patients with low risk early stage breast cancer selected using criteria from the LUMINA trial exhibited excellent local control with endocrine therapy alone if they were treatment adherent. This finding awaits validation in large prospective cohort study. However, ET alone may be insufficient in patients likely to be non-adherent to the treatment, and notably, prospective trials should closely follow up and report ET adherence. So take-home message is that the main challenge is to identify the most suitable subset of early breast cancer patient who will benefit from avoidance of RT. Large prospective studies are needed for the same. Perhaps comprehensive integration of features such as patient's age, comorbid condition, life expectancy, and tumor-related factors, including the classical factors like size, hormonal receptor status, grade, differentiation, and genetic and molecular features may enhance our ability to properly identify patients at low risk of recurrence. Composite endpoints evaluating not only the tumor recurrence rate and OS, but also toxicity, patient's quality of life, psychosocial issue, and cost effectiveness needs to be included to better tailor the clinical decision-making process in low-risk early-stage breast cancer. And patient and clinicians' perceptions regarding the apparent benefit of treatment in specific group of patients needs to be challenged, and the concept of avoidance of treatment to prevent over-treatment needs to be introduced. These are the references. Thank you.